gene therapy has been approved, there was a lack of knowledge about safety and effectiveness of this drug in a broad patient population. And that's also what I will try to explain, that we are still learning and we still need to learn a lot about gene therapy. So to discuss in more detail, gene therapy for SMA, onasemdogen abebavovec, the brand name is Zolgensma. It's an AAV9-based vector, and as you can see, the vector contains the promoter, which is responsible for the expression of the gene, and then the human SMN1 transgene, which is of course also part of this vector. And then important to understand, this is a non-replicating vector, so we need very high doses. So what is the approved dose for Zolgensma treatment is a single intravenous dose of 1.1 times 10 to the 14th vector genomes per kilogram body weight. And it's important to understand, different from nusinersen antisense oligonucleotide treatment, that gene therapy, the dose is proportional to the body weight, so it increases with increasing body weight. So at the time of approval, there were only clinical studies for symptomatic infants with SMA type 1, with the age of up to 6 months. And I mentioned before that this was not placebo-controlled, but nevertheless, these infants, after treatment with gene therapy, achieved motor milestones which had never been observed in the natural history of the disease. So it was quite obvious that the treatment was effective. I'm not going to review these initial trials because I think you are probably all familiar with this. And then the drug was first approved by FDA in the US in 2019. And the approval in the USA put in an age limit. So it is approved for all types of SMA up to the age of 2 years. But the European Medicine Agency took a different approach. So the official approval is for, as you can see here, is for patients with SMA type 1. So this is defined by symptom onset before 6 months of age, and also for all patients with up to 3 SMN2 copies. And this includes also patients with SMA type 2 or 3. And there was no age or body weight limit for this approval. So this was interesting. As I mentioned, clinical data were only available up to 6 months, but theoretically, only considering the label, it would have been possible to treat even adult patients with SMA type 2 and 3 SMN2 copies. But this would mean that you would use a dose, for example, in a 40 kilogram body weight, a dose which is 10 times higher of what has been typically used in infants. And there were basically no clinical data in this population. So, of course, we have learned since then, and just to compare again, so we have 3 different treatments, nusinersen, antisense oligonucleotide, which is applied intrathecally, and after a different loading regimen, you have to use this every 4 months. Then we have the gene therapy. Of course, it is attractive as it's only a one-time treatment, and it is approved for SMA type 1 and patients with up to 3 SMN2 copies in Europe. The dose is body weight dependent, as I said. And then you have risdiplam, which is an oral splicing modifier. It has been approved in Europe since 2021. Originally, infants up to the age of 2 months were not included in the label, but this has now been changed last year. So now it can also be used from birth. And over the years, we have increasing number of patients and clinical experience. So nusinersen and risdiplam have been used in more than 15,000 patients worldwide. And also gene therapy has now been used in more than 3,000 patients. And as you can see in the last line, all these drugs are quite expensive, as often seen in orphan drugs. But of course, you have to consider that gene therapy is a one-time treatment, while nusinersen and risdiplam probably require lifelong treatment. And also the prices are different from country to country, and they are not always public also for some countries. So coming back to the original approval, it was, I think, for the SMA community, it was quite difficult to handle this very broad label without any age or body weight limit. So we joined a team of European experts back in 2020, directly after the approval, and we discussed in which patient populations the use of gene therapy would be safe. And in this committee, at that time, we concluded that probably patients with a body weight of more than 13.5 kilograms should not be treated, or if so, they should only be treated in a clinical trial. So that was the recommendation, not to treat patients with a higher body weight. So after the approval, there were some additional data published, clinical trials performed by Novartis in pre-symptomatic patients. So most of them were identified by newborn screening. And this is the SPRINT trial. And this is the cohort of infants with 2 SMN2 copies. So as you know, the number of SMN2 copies is predictive of the severity. Most infants or most patients have 2 SMN2 copies, and this is predictive of a quite severe phenotype, typically SMA type 1. So if we treat these patients with 2 SMN2 copies, you can see here the achievement of motor milestones. You can see here the WHO window of normal development, and you can see most patients, but not all patients, have achieved independent sitting within the normal window, but some are delayed. And the same here for independent ambulation. In dark red, you can see most patients, if they are treated pre-symptomatically, achieve ambulation, but probably about half of them have delayed ambulation, so delayed motor development. This looks a bit better if we look at the cohort with 3 SMN2 copies, so predictive of a bit milder phenotype, typically type 1C or type 2. So we can see that here the majority of patients, again, pre-symptomatic initiation of treatment, the majority of patients achieve ambulation within the normal window. So now I will present some data from real-world experience with gene therapy. So this is a publication from Claudia Weiss and a network in Germany back from 2020. So here they analyzed different age groups of treatment, and you can see the improvement of job intent scores, and you can see the 6 months time period before gene therapy. Most of these patients were on nusinersen treatment at that time. And as you can see, all patients improved after gene therapy, but just from visual inspection, you can see that on the right side, patients with an age of more than 2 years, there is only very small, or even there's a single patient who deteriorated in the job intent after gene therapy. So you can already here see that younger patients show more improvement on job intent compared to older patients. And you can also see that there is also improvement in the pre-treatment, pre-gene therapy period. And it's very difficult to understand whether the slope or the rate of improvement is changing when you switch to gene therapy. If we look at the safety profile, so typically side effects we see after gene therapy is increase of transaminases, so indicating immune response of the liver, probably mainly vector response of the liver. And you can see here the increase of transaminases. And again, we have the 3 different age groups: below 8 months, 8 months to 2 years, and older than 2 years. And what you can see, if you look at the mean values in the lower graph, you can see in the younger patients, you have typically a peak during the first week or first 2 weeks after treatment. And in older patients, we increasingly see a second peak, typically about 2 months after treatment. And also we see more increases of transaminases in older patients compared to younger patients, and this is also confirmed by other studies. But important also, not only the number of transaminase increases is increasing with age, also the pattern and the time of transaminase increase is changing with age. These are data from the RESTORE registry. So RESTORE is a registry run by Novartis, again, a disease-specific registry for all patients with SMA. Most patients in this cohort presented here are from the US and some other countries, but basically very few or no European patients. So this is a cohort you can see about almost 100 patients identified by newborn screening and 70 patients who have been diagnosed clinically. So you can see here the overall survival. So survival is defined by either death or the need for permanent ventilation of more than 16 hours per day. And again, this is separated by SMN2 copy numbers. You can see in patients with 2 SMN2 copies, and these were 79 patients, we have some mortality, but still this is going down to 90%, so 10% mortality. And this is mainly in patients who were quite severely affected already at initiation of treatment. And in the other population, the rest of patients, we have very good survival, at least in this observation period of about 2 years. But you can also see the numbers at risk. So you can see at 30 months of observation, we have very few patients. So we need more long-term observation data from this data source. An Italian publication, again, here I'm just focusing on the side effects. Very typically, we also see thrombocytopenia. And as you can see on the left side, so these are the total platelet counts over time. And what you can see that in almost all patients, the lowest thrombocyte count is observed 7 days after treatment. So this is also what we see in clinical practice. So typically after day 7, the thrombocytes would increase again spontaneously, and only in very, very, very rare cases there is any symptoms, or you might need to supplement thrombocytes. So typically this goes down, but not significantly below 100,000. And again, on the right-hand side, you can see the transaminases. And again, you can see here the second week as a second peak after 2 months of treatment, which has also been observed in the German cohort. This is another publication which recently came out from the UK, which is interesting because it included patients, older patients, and also heavier patients. Again, here, if we look at the effectiveness, so increase of CHOP intent score, again, you can see the different cohorts separated by age. So you can see the highest increase of CHOP intent in the young infants below 6 months. And again, on the right-hand side, in infants older than 2 years, there's only a very small increase of CHOP intent because, again, these patients were, most of them, in advanced stage of disease. So this is now interesting to look in more detail at side effects. So above, you can see the platelet counts again, but now you can see the correlation of the lowest platelet count observed, and also the weight at infusion. And there is a mild correlation between weight and infusion. And in the lower chart, you can see ALT and AST peak, and there we see a clear correlation. So with increasing weight, we see higher transaminases. So, and that is quite understandable because we need to use higher doses because it's proportional to body weight. So it's understandable that the immune response of the liver is more pronounced in heavier patients. So this clearly indicates that the risks of liver side effects is higher in heavier and or older patients. It's difficult to separate whether it's the age, because it could also be related to the maturation of the immune system, whether it's age or body weight, because of course body weight and age correlate. So some papers indicate that age might be more relevant and others indicate that body weight might be more relevant. And on the upper right-hand side, you can see troponin I levels, and there has been some observation of troponin increase in the mice model after treatment with Zolgensma, and this is why the label recommends monitoring of troponin I. But as we have learned, troponin I levels are often high in young infants, and they, as you can see here, they can even be no, you cannot see it on this graph, but I can tell you from other publications that troponin I can even be high or increased before gene therapy. So we are still discussing the significance of these troponin I values. Okay, and this is another data I would like to show. This is from the Smart Care Registry, which we are running in Germany and Austria. And we have looked again at the real-world experience from newborn screening. So we have about 1,500 SMA patients in our registry, and we only looked at infants born between 2018 and 2021, because in this time period we had a regional pilot project of newborn screening, which was conducted only in two areas in Bavaria and North Rhine-Westphalia. And we only looked at patients with up to 3 SMN2 copies, because these show early onset of disease. And as we wanted to assess the outcome of newborn screening, we focused on patients with up to 3 SMN2 copies. So in our cohort, we identified 276 infants. 62 of them were diagnosed by newborn screening, so were included in the pilot program. And 214 were diagnosed clinically after symptom onset. So this was interesting because often we have used historical controls, but in this study, we could use really a parallel group design in the same health system, and same treatments were available for these patients. So at the end, we could analyze 44 patients in the screening cohort and 190 patients in the clinical cohort. And if we look at the achievement of motor milestones, and before we discuss this more, I should mention that they received different treatments. So there was not only gene therapy. At the beginning, gene therapy was not available. So this is a mixture of treatment, gene therapy, risdiplam, and also nusinersen treatment. But what is important, the clear separation, if we look at the probability to achieve independent ambulation, you can see that 75% of patients in the newborn screening population achieved independent ambulation, and only 20% in the symptomatic, or I should say clinically diagnosed group achieved independent ambulation. If we compare this, because I showed you the pre-symptomatic data from Novartis before, and it's important to understand that those patients in the pre-symptomatic study by Novartis, the inclusion criteria was no symptoms of SMA, while in our study, we looked at all patients identified by newborn screening, and some of them were already symptomatic when they received the first treatment. And this explains why the rate of ambulation is lower in our cohort compared to purely pre-symptomatic patients. And to illustrate this again, within the population identified by newborn screening, we separated again two groups, those who were purely asymptomatic at treatment initiation and those who were symptomatic. So here we can see if a patient is identified by a newborn screening and purely asymptomatic, there's a very high probability to achieve ambulation. But in contrast, if there are already symptoms at birth or at initiation of treatment, there's a very low probability. Of course, these numbers are not too high, but nevertheless, there's very low probability. So in addition to newborn screening, the presence of symptoms at treatment initiation is a very important predictor. And I think this is also very important to counsel families. So if you identify patients by newborn screening, if they already have symptoms, the prognosis is worse compared to those who have no symptoms. Okay, so to summarize the real-world experience about onnasemnogene avuparvovec, I think I have shown you the most important predictive factor in symptomatic infants is the disease status at initiation of treatment. And we have also seen that several publications have shown that the effect size is limited in advanced stages of the disease. So this was mainly in those populations above the age of 2 years. But as I said, SMA is a continuum, so there's no clear age limit or severity limit which we can define. But the more severe, the more advanced the disease, the less improvement we will see after gene therapy. And unfortunately, there's no head-to-head comparison comparing gene therapy to one of the other treatments, so nusinersen or risdiplam. So it is still difficult to judge whether any of these 3 treatments is superior to any other. Of course, the one-time treatment is attractive, but apart from that, we know different safety profiles. But at this moment, I think there is no really convincing evidence that one treatment is better than the other. So there's still a need for additional evidence. And I think you all know, and I have shown you, I think newborn screening and early initiation of treatment is really crucial. And definitely this is more important than the choice of the drug. And if we talk about pre-symptomatic infants, it's also clear if we have no symptoms, of course, we can only use SMN2 copy numbers to predict the severity. And as I have shown, even pre-symptomatic patients with 2 SMN2 copies show often delayed motor development after gene therapy. If you have 3 SMN2 copies and initiate treatment early, you might see normal achievement of motor milestone during early infancy. There are also some publications, but this is still very limited, about the potential cognitive involvement in patients identified early and treated early. But I think we still need more data to really confirm if we might see developmental problems in addition to neuromuscular problems in patients with 2 SMN2 copy numbers treated early by one of the 3 treatments. Concerning safety, to summarize, I have shown you that hepatotoxicity is very common as an immune response of the liver to the vector. And we need to treat all patients with steroids, and due to these side effects, it's often required to either increase or extend the use of steroids. And this is more common in older and heavier patients. And we also quite often see thrombocytopenia, but typically there are no symptoms and treatment is not needed in most cases. Yeah, and as I had mentioned now several times, side effects increase with age and body weight. And there are very rare cases have been reported with severe adverse events, even life-threatening, like thrombotic microangiopathy or liver failure. And again, I mentioned at the beginning the limited number of patients before approval. So all of these cases have not been observed in clinical trials, which is quite understandable, as only 40 patients were included in clinical trials before approval. So this experience all stems from real-world data. So this again illustrates how important is the continuous collection of evidence for effectiveness, but also for safety. So as a European reference network, I think we should also have a look at the availability of these treatments across Europe. And this is a very nice website which has been initiated by SMA Europe, a patient organization, I think with support from different pharmaceutical companies. And here you can see the different treatments and whether the availability is good or should be improved or is not good in different European countries. I don't know the details, and I think we all know that, for example, nusinersen is not available for all patients. In some countries, it's not available for adults, for example. But you can see here that there is relatively good availability, and I'm also not sure how up-to-date this data is. It might be from last year, but I'm not sure. If we compare this also, Evrysdi there's quite good availability in different European countries. And just it's interesting for comparison, this looks a bit different for gene therapy. So it's probably also due to the novelty of this approach, gene therapy, and also the high price for single treatment. So the availability is limited in many European countries. But it's also difficult because some countries have put limits concerning the phenotype, for example, only approval for SMA type 1, or limits concerning age or body weight. So this is also the limitation in some countries that's only available for specific populations. And last not least, if we look at newborn screening, here you can see many countries have now show up in green, so they have implemented newborn screening for spinal muscular atrophy, and I'm especially impressed by the Ukraine, because Ukraine has also, during the war, has now been able to implement newborn screening for spinal muscular atrophy, which is, I think, quite impressive considering the situation of the country. And in some countries, we have still pilot projects, and also I'm not sure in all countries where a national program has been implemented, whether really all infants are included in these newborn screening programs. But we have now broader availability of newborn screening, and I think we all know how important this newborn screening is to improve the prognosis for these patients. So I mentioned the European consensus statement back in 2020, where we defined a body weight limit, or proposed a body weight limit of 13.5 kilogram for the use of gene therapy. And I've also shown you the increased availability of clinical data. Sorry, I should probably go quickly back to the data from the UK, because I didn't mention specifically here. You can see the body weight, and you can see here that they included patients with a body weight of up to 20 kilogram. So, and there has also been a study by Novartis, again, an open label study without a control group, where they also included patients with a body weight of up to 18 kilogram, but this has not been published yet in a peer-reviewed journal. So considering this additional experience, we now reconvened in a broader consensus group. So we included additional people from additional European countries, and many of them are also members of the European Reference Network, and we discussed again the available evidence. And so we revised consensus statement 5. So we discussed that it's probably not appropriate. Again, there's no justification to define a strict body weight limit of, for example, 13.5, or no increase to 15 or 16 kilogram. And instead, we just agreed on a statement that the side effects are proportional with weight and age, and heavier and older patients should be treated very cautiously. And also, of course, we have alternative treatment with nusinersen and risdiplam, and these should be considered in older and heavier patients. But it's now, I think, an individual discussion of risks and benefits of different treatment approaches, and also availability between the treating physician and the family. Okay, there's sometimes also discussions about combining different treatments, and I think there has also been sometimes, or there's still confusion about the definitions or nomenclature for different treatment combinations. And here's a proposal which has been published last year by a group of international experts. And one proposal is to use the word switching. If you change treatment after more than 3 months on the original treatment. For example, if you start with nusinersen treatment, then after 4 months of treatment, you switch to gene therapy. The proposal is to call this switching. Different from switching is probably the bridging. So bridging refers to the concept to use a treatment just to bridge before you can use another treatment. So, for example, to start in a patient identified by newborn screening with 2 SMN2 copies to start treatment with risdiplam. It could be because gene therapy is not readily available, or AAV antibodies might be positive due to placenta transduction, and you could wait for the treatment with gene therapy. And in this paper, they proposed to use the word bridging if the initial treatment was only used for less than 3 months, and from the beginning it was already planned to switch to another treatment. And then there's also the term of add-on therapy. So this would mean that you combine 2 treatments that work simultaneously. So, for example, you start with gene therapy, and then you might see insufficient response. And this often, as I showed you, often happens in advanced stages of the disease, that you see very limited response. So here the idea would be to add another treatment. So we assume that the effect of gene therapy is ongoing over several years. So then we would call this add-on therapy if you use risdiplam or nusinersen in addition to gene therapy. And we also discussed this in our consensus group, the combination therapy. And there are some studies ongoing examining the use of nusinersen after gene therapy, or the use of risdiplam after gene therapy. The problem of these studies is they don't have a control group. So, I mean, after gene therapy, patients tend to improve over quite a long period. So it's difficult to know if you add another treatment, whether the effect you see is due to the gene therapy or whether it's due to the addition of another therapy. So based on this, we had a consensus of 95%, as you can see here, that probably at this stage, there is no convincing evidence that a combination of 2 treatments is superior to the use of a single treatment, considering also the fact that both have the same mode of action by increasing SMN protein expression. And it would really be nice to have a controlled clinical trial with a head-to-head comparison to really be able to evaluate if adding a second treatment is superior to a single treatment. And also, of course, the economic responsibility. It might be difficult to use 2 of these expensive treatments simultaneously without the evidence supporting this. And then we also added another statement, so I will not review all the statements, but we also added a statement on the importance of newborn screening. I think it's quite clear that newborn screening should be implemented in all countries where at least one disease-modifying treatment is available. And I think it's also important, I mentioned that some patients are already symptomatic after identification by newborn screening, and often the symptoms could be very subtle. So it's very important that an experienced pediatric neurologist should evaluate these patients as soon as possible. And if they already have symptoms, it's very urgent, but also if they have SMN2 copy numbers, which are predictive of the severe phenotype. So this means 2 or 3 SMN2 copies. Treatment should be initiated as soon as possible. And as I mentioned before, probably the choice of treatment is not that important. What is more important is only to avoid any additional delay in treatment initiation. And even if you plan gene therapy, it might be appropriate in some of these patients to use risdiplam or nusinersen treatment as a bridging therapy. If you cannot use gene therapy within a very short time frame, you to, I don't know, approval by insurance companies or pre-tests that are required for gene therapy, for example. Okay, so to conclude, I think I have shown you that gene therapy offers an attractive treatment alternative for infants with spinal muscular atrophy. And I have mentioned several times, but I think it's very important because sometimes you hear and you compare apple and pears and you say this patient received gene therapy and learned to walk, and this patient received nusinersen and never learned to walk. But I think the most important factor is really the baseline status when you initiate treatment of the patient rather than the choice of the drug. And as it's important when you discuss with families to stress this. And for all treatments, best results are seen in pre-symptomatic patients identified by newborn screening, but still, even if they have symptoms, the prognosis is better if they are identified by newborn screening, because there would be additional delay before they would be identified by clinical diagnosis. Nevertheless, I think despite the treatment, those patients who have already symptoms at treatment start, they often remain with significant disease burden, and there is still unmet medical need, I think, and I think additional drugs could be helpful for these patients, and there are clinical trials ongoing, for example, exploring myostatin blockade, which could be one option and would have a different mode of action, not only SMN2 protein increase, but a different mode of action. So this could be a perspective for those patients who are already symptomatic and remain with symptoms after treatment initiations. And with this, I would, and last not least, I think I have shown you how relevant the real-world data is to learn more about effectiveness and also side effects. So most of what we now know about effectiveness and side effects comes from real-world data and not from the pivotal clinical trials before approval. And with this, I come to my end, and I'm happy to take any questions. Thank you very much.
Thank you very much, Jan, for this wonderful presentation. Well, now it's time for questions. If you have questions, you can write them on the question and answer chat. And there are no questions by now, but I hope that you will write something, but I have some questions. When you talk about the add-on therapy, I think that it is very difficult or almost impossible to say if there is an insufficient response or not. No, because it depends on each patient and the evolution of each patient. Do you think that we will be able to have some points? Because sometimes we have patients that will be able to participate in a trial after one therapy. No, if how can we say that the response has been insufficient?
Yeah, I think it's difficult. So what we discuss with patients, if we use gene therapy, that typically we would expect gene therapy to last quite long. So we have now observation periods. The first patients have been treated about 6 or 7 years ago, and we know decline of motor function has been reported. So what I clearly state, if we see a decline of motor function, for example, after 4 years, 5 years, that could be an indication to say, okay, there is, I don't know, there's no continued effect of gene therapy, then we might add another SMN protein increasing or splicing modifier. But otherwise, from most patients, I see, of course, I mean, if you say, often we hear suboptimal response, and I would say every patient which is not cured is suboptimal from a patient perspective, and also from my perspective as a physician. If the patient is not healthy, it's suboptimal, because optimal is also there are no symptoms. So this wording, I find it very difficult. How do you define suboptimal response? But sometimes, of course, you might see no response. I have never seen this. If there's no response to gene therapy, no improvement in a patient not in advanced stage of disease, and you are really surprised and you would not expect this, then you might discuss. But personally, I have to say I have not seen these patients where I did not see the response, which was in the range what we would expect after gene therapy. But I agree. I mean, it's difficult to define suboptimal or poor response as we expect suboptimal response or poor response in advanced stages of the disease. But still, when we discuss with families, we often see, and I think you also know this and many others know, there are very high expectations, and typically expectations are higher for gene therapy than for other treatments. And you can talk to them for hours and explain to them that the baby will never learn to walk because it's already quite severely symptomatic. Nevertheless, they hope that the patients, and they expect somehow, and there's often also frustration in these patients that the outcome is not as good as parents expect, despite extensive discussion.
Okay, thank you. There are 3 questions. One is by Corrado Angelini, and he asks if there any muscle biopsy after gene therapy, the need for muscle biopsy.
No, I think there's no need for muscle biopsies after gene therapy. And I mean, what would be interesting, but we cannot do this, and of course it's not justified, is to look at motor neurons and to look at the expression of SMN protein in motor neurons. That would, of course, be interesting. There have been some data on patients who died after gene therapy, but muscle biopsy, I'm not aware of any muscle biopsy after gene therapy.
Okay. There is another question from Askat Mukushev. Could peripheral tissue that contains SMN have impact on clinical picture or treatment?
Yeah, that's an interesting question. So we know that SMN protein is ubiquitously expressed in the body and in many parts of the body, but we don't really know how important SMN protein is in different tissues. And so we have systemic treatment with, of course, risdiplam, and we have CNS treatment with nusinersen only because antisense oligonucleotide is not passing the blood-brain barrier. There are some discussions if a systemic treatment might be better and you might see better results for swallowing and bulbar function. But I think there's limited data. This has not yet been proven. And also end plates might also be involved in SMA pathology. But I think there's no proof yet that the systemic treatment is superior. But it's an interesting question. And I think we need long-term data to see whether we see a difference concerning other tissues.
Thank you. There is another question from Ferdows Ara Islam. Is there any improvement in life expectancy in new current treatment strategy?
So if I understand correctly, of course, life expectancy is improving dramatically by these new treatments. So beforehand, SMA type 1 infants, so those with severe phenotype onset before 6 months of age, almost all of them, or at least 90%, died during the first 2 years of life, or they required permanent ventilation due to respiratory insufficiency. And now, if we initiate treatment early, if we initiate pre-symptomatically, they survive without bulbar problems, without respiratory support, and they achieve often normal motor milestones. So this is very impressive, from 90% mortality to survival and independent ambulation. But this requires a combination of newborn screening and treatment. So it's not only the treatment. And yes, so we see quite impressive improvement of survival in this population. But of course, if you treat very late, as we discussed before, there might be limited improvement. And if a patient, for example, already is on ventilation, on permanent ventilation, I think it's quite unlikely that you will be able to stop ventilation due to the treatment. So it's really the stage of the disease that is important for the prognosis.
Okay, there is another question from Seliko Uzelak. When will intrathecal gene replacement therapy for SMA become available for adults, considering it is currently in phase 3 trials?
Yeah, that's interesting. Thank you for mentioning this, because it's an important point and I did not touch on this. So there's also the idea to use intrathecal administration of gene therapy, because as I discussed before, in older and heavier patients, you need very high doses to get a sufficient transduction of motor neurons if you give it intravenously. So the idea is to use gene therapy intrathecally with a lumbar puncture. So then it might be easier for the vectors to transduct the motor neurons. And this is currently in clinical development. But the clinical studies, the phase C studies, they are also performed in children. So these are children with SMA type 2, older and heavier children, but not in adults. So we will see. I think it's the decision of FDA and then later also EMA. If this is the safety profile is considered safe enough, but I think that's an interesting approach, and we will need to see whether approval will be limited to children with SMA type 2, or whether this might also be an opportunity for adults. But yes, this is a possibility. But again, we don't know yet in chronic stages of the diseases how much effect a gene therapy might have in adults. So there is also, we would need additional experience and clinical data to really see. As all those who see adults with SMA, we see that the improvement is often limited in adults compared to infants. Also, if we use risdiplam and nusinersen, and I would expect a similar limitation also for the use of gene therapy in adults. But yes, intrathecal application might be an option for adults with SMA.
There is another question from Josep Gamez. What criteria should be considered to suspend these treatments if we do not observe any benefit? How would you communicate this to parents?
It's very important. So, I mean, to stop treatment, I mean, that's not an option for gene therapy. So that's an advantage, but also a risk, of course. If you have side effects, you cannot just stop the treatment. But of course, we need to discuss this in cases treated with risdiplam or nusinersen. And then I think it's a very difficult discussion, because we often see, even if in advanced stages of disease, we often see stabilization of disease, even if there might be a low level of motor function, but even stabilization in this life-threatening diseases can be very important. So it's difficult, but we also mentioned in our consensus paper that in some instances, for example, if you have infants already severely affected, you should really discuss also the limited benefit we expect from treatment. And in these very severe cases, palliative care might also be an option. So if you know, despite treatment, you might end up with permanent ventilation and tube feeding and very limited motor function, I think it's also justifiable, at least, to discuss the option to go for palliative treatment in these severe cases. But it's difficult to discuss this, I agree, but we also need to address this, I think, from our side with patients.
There are not more questions in the chat, but I have one last question about troponin I. Do you think that we should monitor troponin I in these children? I don't know, to know the variations because of the therapy, but also about the infections or other situations.
Absolutely, yeah. So I think it's of very limited value, and in those patients where troponin I increase has been observed, there was no cardiac abnormality in echocardiography or ECG, so probably it's just a laboratory finding, but it's not clinically meaningful. The problem is that this is mentioned in the label, so it's recommended to monitor troponin I, and I think we should really discuss again what is really needed to remove these recommendations from the label. But I would say as long as it's mentioned in the label, we need to do this. But I think most clinicians, they measure this, but okay, if it's increased, they do an echo and they do an ECG, but we are not really concerned about high troponin I values, and we all agree that they are of limited value. So yeah, I think after now more than 3,000 patients have been treated, it would be nice to collect some evidence and to argue that troponin I might not be helpful in the safety monitoring for these patients.
Okay, well, there are no more open questions and it's almost time. Then thank you again, Dr. Kirschner, for the presentation and your answers.
Okay, thank you. It was a pleasure. Thank you. Goodbye to everyone.
Goodbye.